Dr. Gupta is currently the ICMR Chair of Epidemiology and was the founding director of the National Institute of Epidemiology in Chennai. Early in his career, he worked as a WHO epidemiologist for smallpox eradication campaign in Uttar Pradesh. Dr. Gupta has pioneered BCG vaccine trials in the country and the field study in Tiruvallur, Tamil Nadu. He is internationally known for his work in leprosy detection, surveillance and treatment. His study also revealed the partial protection of leprosy by BCG vaccine. He currently heads the ICMR task force on development of guidelines for diagnosis and management of rickettsial diseases in the Himalayan regions. For his role in leprosy control in India, Dr. Gupta is to be awarded the International Gandhi Award for Leprosy at Wardha, Maharashtra by the Honorable Vice President of India. Unfortunately, he was unable to attend due to his respiratory problems and has sent his apologies. It is my great honor and pleasure to introduce our last speaker, Dr. Saurabh Gupta. Dr. Gupta is a fellow of the Faculty of Public Health and has worked as consultant in public health in UK and India in the field of family health, child health, nutrition, health systems, infectious diseases and immunization. Interestingly, he is an orthopedician by training and continues to maintain his interest in orthopedic surgery. He is currently with the Government of India, Ministry of Health and Family Welfare and leads the Secretariat of National Technical Advisory Group on Immunization. He is the Director of Ambition Health Private Limited. He has agreed to be a consultant medical epidemiologist for Narvi Hospitals. He is presenting on the topic high-tech private sector hospitals can profit from investing in public health. Ladies and gentlemen, we present to you Dr. Saurabh Gupta.
Thank you. It's a pleasure to be here and thank you for inviting me here. Before this presentation began, we were discussing with Dr. Jacob John that public health is not charity. The public health needs to generate profit in order to be financially sustainable. Now, what I'm trying to show today is actually private hospitals can benefit from investing in public health. Next slide. And it's not only me who says that. Bill Gates has said this as earlier this year, that private sector can profit from public health, and he's gone to give concrete examples of that. But the question is, why do we need public health? Purely because we know that there's pill, knives, gene therapy, or devices, they don't work. And I realized that quite early in my career being an orthopedic surgeon, that by cutting and this thing, I cannot cure things. So public health was the way I was going to look forward for in my career as well. And public health makes it quite complex to address. Clinical prevention, research, initiatives, and a host of other measures which have to be done to address public health. Next slide. And that's important because health is driven by multiple factors which are linked, of which medical care is a small component, which is only 10%. Some part of this, like family history and genetics, you can't change. But personal behaviors and social factors is what we try and address in public health. This is a slide from the Global Burden of Disease, which was released last month, and shows the deaths which happened in Tamil Nadu in 2016. A large proportion here is because of cardiovascular, ischemic heart disease, stroke, hypertension. Some part is diabetes, kidney disease, COPD, and as my speakers before had said, around 60% of this is from non-communicable disease. But when they come to a hospital, they come as separate diseases. But if you take an approach to them which is integrated, you see there are 4 diseases: cardiovascular, cancer, chronic respiratory disease, and diabetes, which have 4 risk factors: unhealthy diet, inactivity, tobacco, harmful use of alcohol, and have 4 different actions: support the individuals, encourage groups, change communities, and track outcomes. Looking at them in a bit more detail, if you go individually, we know what you do. Screen someone, advise them, assist, refer, and then follow up as to what has to be done, and do it with every single person using the tools which we already have. Taking the example of cardiovascular disease, we know there's good evidence that if you reduce your blood pressure by 13 points, your risk goes down by 25%. You give 4 medicines like aspirins, statins, clopidogrel, you reduce your cardiovascular events by 50%. You have 7 key interventions in the hospital, you reduce your mortality. If you manage transition of patients, particularly like heart failure, from hospital to home, you can prevent a lot of readmissions, which gives rise to benefits. But what is required is a systematic approach, crossing the things of primary prevention, secondary, acute care, and chronic care, and accountability across the whole spectrum, from prevention to management of acute. And what happens currently is, we are looking only at acute episodes when they come in hospital, but forget the remaining parts of the bridge, and therefore the problems sometimes come in. So again, looking at cardiovascular as example, primary prevention is modifying the lifestyle, increasing hypertension control, smoking cessation, and reducing the bad cholesterol. And specifically dissecting this process further, if you come in a hospital, you check, was the BP taken, recorded, was it high, and measure the outcomes for that, treat it, and then repeat it after things, and at each stage, ensure you have outcomes which are easy to follow, which enables action. When you do this, you deliver the benefits, and worldwide, if you look at the evidence, this has been done by preventing heart attacks and stroke in what is called phase, using heart protective medications like statins, aspirins, lifestyle changes of tobacco cessation, physical activity, healthy eating, and risk factor control like blood pressure, cholesterol, and blood sugar. And finally, when the patient comes in hospital, delivering the best practice guidelines which are evidence-based and providing reosculation to the appropriate patients. And this is probably the most important slide of this. So the Case of Permanente is an organization in US which very much is not for profit like Narobi is trying to be, but it delivers a very quality of healthcare, had revenues of $67 billion as of last year, with profits of $1.2 billion, treating around 10 million patients. Next slide. And if you look at this slide, when they took on the primary and secondary measures, the acute myocardial infarction or heart attack cases went down from 6,400 to 5,100, or drop of 20%. But importantly, the mortality dropped by 50%. Now this is key. This is very important because they dropped 1,300 cases, but dropped their mortality first. So they built a reputation, they built trust, which is key in these times. But if you think for each admission dropped 1,300, every single patient would require so many 100 people to be treated to drop that. So they had to do so many outpatient activity increased. You also increased so many blood testing because they had to be checked for cholesterol, their blood sugar, and so many medicines had to be sold. So if you put that in a business case, it's actually quite profitable for the hospital to invest in primary care and secondary care, if you put the numbers together. And that's just cardiovascular. You've got a host of interventions which are well known to work. Breast cancer screening, cervical cancer screening, childhood immunization, treatment in upper respiratory infections, weight management problems, diabetes care, falls prevention for older people. Each of these can actually be a good, profitable measure on its own. Going to the community, we can address people level at healthcare, at schools, work sites, which is the hospital here, and neighborhoods. And these are a few of the things given. So in healthcare, make BMI as a vital sign, promote breastfeeding, make sure the cafeterias are offering healthy foods. In schools, try and input good cafeteria reforms, have regular checkups, physical activity standards. At works, make sure your staff are immunized against infectious disease, have stable prompts, support lactation, and have wellness programs like yoga in the morning, meditation, and so on to promote the work sites. And try and develop parks, promote the economy by farmers' communities, and so on. Which moves us into an area of what is called as holistic health or total health across the world. And these are again examples based on evidence throughout the world which works, which is working, which we can adopt in India with Narobi and other hospitals. And we can decide focus areas. For example, Dr. Sridharan had mentioned one of the focus area could be old people. So you could target that and start developing that is the population. It could be the workforce which is being employed by the hospital. And then develop an integrated care model for the different work streams. So, as I was speaking to Dr. Henry earlier, you've got a team of different people, neurosurgeons, orthopedicians, who are in place, which are the bricks. And the mortar could be the public health, which makes the whole system work together, have an integrated care model, have effective communications, and then have simple messages. Everybody walk, try and ensure the weight is there, encourage healthy eating, which builds a brand of the hospital and generates a good image and generates profits as well. These things don't happen in isolation, and for the management of this to work, levers are required at the management level, at the CEO level, which is ensuring there's a multi-speciality group practice so people benefit across the system. You have clinical leadership, which is very well there with, here, for example, Dr. Paul Henry leading as clinical leadership. Incentives which are aligned to that, champions, and 2 points that are in bold, which is you need to be able to measure that by looking at data which comes in, see the capacity for change and speed of improvement, patient engagement at all times, good project management, and rewarding and recognizing people, which is the key thing as you move forward. And finally, I call this the step. It's actually double E, but step in terms of what you want to provide. You want to have services which are safe for a patient, which are timely, as given at times, which are effective, using evidence-based guidelines, efficient, which are cut off all the waste expenditure, reducing costs, and are patient-centered. So no care about me without me, taking the patient. Thank you.
I request Dr. Manikam to give away the memento. Well, ladies and gentlemen, the floor is open for questions to the speakers. So, I presume I can move on. So, I take this opportunity to thank all the speakers, Dr. Arun, Dr. Manoj, and Dr. Saurabh Gupta, to have accepted our invitation and flown down all the way to grace the occasion and to have delivered such a wonderful speech. And I'm sure this topic and this subject which they have covered would have already kindled the interest of quite a few people, students, other professionals as well. And as mentioned earlier by our chairman, we are sure to conduct such programs in the future also. And I would like to have my special mention of thanks to Dr. Sridharan and our chief guest, Professor T. Jacob John, for having graced the occasion and to have accepted to take our recognition. I would like to give a special mention to Dr. Balaji also to have attended the function. Thank you, sir. Ladies and gentlemen, national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।